Right, we might have enough to get us started. So good afternoon, everyone. Thank you so much for being able to join us this afternoon. I'm Dean Bugay. I'm the Children's and Behavioral Health Manager with the Office of Main Care Services on the policy team. And we are hopefully all here today to talk a little bit about crisis services, both mobile crisis and crisis residential, as we embark on some reform of our delivery model for our mobile crisis. We want to kick off some conversation on that today and then talk a little bit about the rate study ahead. So I know I just introduced myself. I'd like to give the opportunity for our department staff to be able to introduce ourselves. So maybe we could start with the main care folks. Do we want to do Olivia, then Kylie?
Sure. Good afternoon. Olivia Alford. I'm the director of the Delivery System Reform Unit at Main Care, and we are helping out with some of the exciting mobile crisis reforms that Kylie will talk about later this afternoon.
And I'm Kylie Wilkins. For those of you who don't know me, I am the project director of the CMS Mobile Crisis Planning Grant, which is affording us the opportunity to do this mobile crisis reform work. And I think, is that all of us from Main Care?
Nope, I think there's a few others from Main Care. So if some other Main Care folks wouldn't mind just hopping in. The screen's bouncing around a little bit, but I think I can see Melanie and Allison.
Hi, I'm Melanie Miller, and I'm also with the Office of Main Care Services in the policy division, and I am the policy writer for Children's and Behavioral Health Services.
Thanks, Melanie. You went out in and out just a little bit, but she's the policy writer on my team if folks weren't able to hear that. So thank you. And then Allison.
Hi, Allison Weeks, and the new SUD program manager for the Office of Main Care.
All right, then I'd like to opportunity to introduce some of our counterparts over in the Office of Behavioral Health. I think Bree, if you could start and then maybe hand it off to any of the folks on your team who might be on board.
Great, I'm Bree Maselli. I'm the Mental Health Division Manager at Office of Behavioral Health, and I oversee our crisis services. And I'm just looking to see if Cindy is on. And I am not seeing her, so I will jump to our colleagues at Office of Child and Family Services and toss it to you, Ellie.
Hi, I'm Elaine Larrabee, and I'm Crisis Program Specialist with Children's Behavioral Health. And I think Jessica is here.
Not seeing her yet, but that's okay. I'm sure she can say hello when she's able to join in. I have just a logistics question. We have a slide deck to share and some other introductions to do. I know our friends over at the Health Management Associates or Burns and Associates are going to be talking a little bit today and introducing themselves shortly. But Kylie, I'm wondering if you have the opportunity to share screen and maybe pull up maybe the introduction slide and the agenda.
Just to share, I think there may be some folks in a Teams room instead of Zoom.
Okay, I'll go in there, Dean, and ask them to move over.
Okay, that sounds great. Thank you.
Do you want me to move to the agenda, Dean?
Yeah, why don't we move over to the agenda? So as we're thinking about today, we just did some state introductions, and I held off on Burns because we're going to hand the microphones over to them next, so they can introduce themselves and talk about the work that they do. And then so after we do that, we're going to get right into the scope of work. We're going to talk a little bit about the ideas that we have for the mobile crisis work. As folks may be aware, we've received a planning grant from our partners at the Centers of Medicare and Medicaid Services to really take a look at our mobile crisis delivery system and to think about doing some really substantive reforms to help improve the service, think about access, think about training opportunities, and Kylie will be getting into all of that shortly. We'll talk a little bit about crisis residential and some of the pieces that we're thinking about for the future, go over any kind of questions. And then after that, we'll turn the mic back over to Burns and Associates to talk a little bit about their rate setting approach, rate study tasks, and work as that's going to be moving forward. So before we hand the mic over to Burns, does anyone have any questions about sort of the flow of the afternoon? Hearing none, I think it's okay to maybe invite Stephen to the mic.
Thanks, Dean, and probably should have worked a little bit more closely with you on the choreography. Just want me to provide a brief overview of the organization and our role here. Is that the goal?
Absolutely. Yep.
Okay. So good afternoon, everyone. I've met a number of you in the past, but for those of you who I've not met, my name is Stephen Plowski. I'm with the Burns and Associates Division of Health Management Associates. We still typically just refer to ourselves as Burns, but we sold the company a few years ago, and now we're part of HMA. We've been contracting.
Sorry, I'm so sorry to interrupt. I think I'm seeing someone's Teams chat. Just want to let them know. I don't know. Looks fine, but okay, thanks.
My organization, Burns and Associates, has been contracting with the Department of Health and Human Services in Maine, I think since 2013 or 2014. And over that period of time, we've led rate studies on a wide variety of sections of Maine care policy. Many of those have been implemented, a handful have not. And for this particular engagement, this is actually part of a broader initiative that I think folks are familiar with, just to look at kind of the continuum of behavioral health services. So in addition to looking specifically at crisis services, we're also charged with undertaking a review of others services covered under sections 13, 17, 28, 65, and 92. And some of you have been part of those meetings, and we're a little bit further along in that process. But because of the unique nature of what the state's looking to do on the crisis side, to really revamp the system from beginning to end, it made sense to make sure that we're moving forward at the same pace and allowing policy to be, or rates to, I should say, be married to policy. So I think a little bit later in the agenda, we'll talk specifically about our role and how we'll be supporting the department's work as it relates to evaluating reimbursement. But for now, just again, my appreciation for the opportunity to work with all of you, looking forward to getting involved in this exciting project. I'll note that I'm joined by one of my colleagues. Carl, are you available to provide an introduction? He's on vacation this week, so.
Yep, I'm here.
Okay, there he is. He's wearing a tie on vacation and everything.
Yep. Take it up there. Yes, I'm Carl Manzer. I work with Stephen on these projects for Maine. I've been doing this for about 3 or 4 years, the last couple of projects for Maine. So glad to be part of it and glad to be working with you.
So I think that's all from us for now, Dean. We'll come back in a little bit to talk about our process, right?
Absolutely, yeah. We'll jump in and talk about some models, and then we'll get into process and next steps after that. So very good. Maybe we could jump back into the slides, and I might ask Kylie to go ahead and take on over.
All right. So the scope of this work is the costs associated with meeting the CMS definition of the qualifying community-based mobile crisis intervention. And our goal is to receive the enhanced federal match that is offered if we do meet that qualifying standard. That's 85% compared to our usual 50%. We're also going to be updating the methodology for crisis residential, as Dean mentioned earlier. I just wanted to call out that this study does not include items related to the main crisis line, crisis receiving centers, or certified community behavioral health clinics, as those are outside the scope of the CMS planning grant and the residential rate study. So it's important to have a framework to help us understand how mobile crisis is going to fit. There's been a lot of conversation about crisis services nationwide as a result of the rollout of 988 and the initiatives from OPH, OCFS, and ODES, as well as Maine Care, on trying to make sure that we have all of the pillars of the national best practices, someone to talk to, someone to respond, and a place to go. We're really focused on someone to respond for the mobile crisis piece, but we do need to have a framework in which to build that piece into the best practice and how that looks in Maine. So we have a draft of a mission statement to ensure immediate, equitable access to welcoming, hopeful, trauma-informed, recovery-oriented behavioral health crisis services in the most supportive, least restrictive setting. Ensure every person gets the right response every time, prioritizing safety and promoting future well-being. So we think that that's a great foundation for this work. And then we also have some guiding principles, which here they are, and then I'll get into a little bit more detail about what those mean in the next couple of slides. So safety is foundational, and it's important to have a good understanding of our definition of safety, which I think is something that is complicated for law enforcement versus mobile crisis providers, and different scenarios have different expectations for what safety is. But in our mind, we want it to create welcoming, hopeful, trauma-informed experiences for everyone, including high-risk populations. We want to enhance our processes, including peer support, maximize de-escalation, and emphasize hope and successful resolution. Ensure that patients or clients are placed in settings that best match their acuity and safety needs. This is particularly important because there's lots of evidence to show that high acuity individuals placed in low acuity settings are unsuccessful, and also vice versa. If someone is low acuity and placed in a higher acuity than necessary setting, that can be traumatic or not as effective. And then the no wrong door concept is something that's key for this project, and also in our future work with the CCBHC model, making sure that people are accepted and not turned away wherever they present. And if someone presents to a setting that's not the appropriate level of care, making sure we have clear processes to get people smoothly transitioned to the appropriate level. And then the crisis experience is more than a single event. I think this is something that has become so clear in our conversations when I was with the Office of Behavioral Health before, speaking to all of our wonderful crisis providers, that crisis is more than just that immediate moment. There's prevention, intervention, and stabilization. All of these pieces of the crisis experience are important. And we want to make sure that the model that we build encompasses the whole experience, enables providers to do community outreach training and education, provide resources to community organizations, intervention, and have the capacity to meet people where they are and provide them with what they need in the moment, without exclusion, and stabilization, that care coordination and that warm handoff between levels of care, or providing that bridge between high acuity and back to the community. Some of the work that's been done with OCFS and the crisis aftercare model also inspired us to highlight the crisis stabilization piece as well. And finally, the capacity for complexity. We want to make sure that there's competent care for individuals across the lifespan who may experience a variety of complexities. We've called out a few just because there's some of them are called out in the CMS Mobile Crisis Planning Grant, such as inclusion of individuals with active substance use disorder or primary substance use disorder. But then also, according to the National Best Practice Guidance and just conversations with providers and stakeholders, it's clear that we need to have the capacity to meet the needs of all people. And that's a really big, broad stroke, but ensuring cultural safety, making sure that we are mindful of people who might have physical limitations and co-occurring conditions. There are obviously other things that we need to consider as well, but this just gives an example of how we're hoping to create dynamic teams who are able to address individual needs in a variety of circumstances. So that was our framework and our guiding principles. And now we'll talk a little bit about the mobile crisis service. I'm going to pass it to Olivia. Olivia, I'm happy to continue to manage the slides, but she's going to talk about the delivery system reform process.
Thanks, Kylie. So for those of you, who might be providers of other services and you've started to go through the rate study process, I should say, with let's just say the team here from Burns and Associates, you've jumped right to rate setting. To what are the rate inputs? How have the ratios changed, labor costs, et cetera. This mobile crisis work is definitely following a different path. And what we're doing again today is just kicking off this work with you all. We need to first design the care delivery model. One of the biggest things about delivery system reform is that you don't let rules around payment and preconceived notions about things that you need to think about later define what the care delivery model in an ideal state would look like. So Kylie will talk more about this, and she's been working with stakeholders and providers and teams internally and learning nationally about mobile crisis. And that's also part of what Burns and Associates is supporting us with in learning about nationally how are these services delivered and designed. So right now we're delivering designing the care model. The next thing is, okay, what's the payment mechanism to support that ideal care model? It may seem like a small adjustment, but it is really important to do that next. Do that after you have the care delivery model. What we anticipate, again, we don't know the answers, but what we anticipate is that we won't end up with a payment model that is a 15-minute billable unit. We have heard loud and clear, and nationally it's known, that might not be for service, 15-minute or other unit-based reimbursement, such as that may not best support some of the care delivery aspects that we want to see and we'll talk about today. So we're open to alternative payment models. We're open to other ways to pay for this service. Again, that's part of like the longer process of reforming an actual service model. So we will decide the payment model. We will then decide the actual payment rates that go with that model. That'll all happen in the next number of months. And then the next part is pretty typical. The next part is Medicaid has to seek federal approval for that process, for those rates, that payment model, that coverage, all of those things. We have to promulgate or disseminate main care regulations, seek public comment, do the normal things that main care does to make something happen. And then again, if we need additional funding, we would have to ask for that or find that funding. And then part of what delivery system reform often includes is the ongoing monitoring and oversight, which happens in crisis actually a lot already today. And there's lots of really good work that we could talk about for hours about data-driven oversight of crisis services. And then throughout, we have obviously a lot of other activities around stakeholder engagement and prepping our systems and doing lots of communication. So it's just a high-level overview. And this does tie to something that main care has been very clear about, that we want to move towards alternative payment models. We have set ourselves a goal of getting to have 40% of our payments tied to alternative payment models by the end of this year. And I'm not going to go into this in a ton of detail, but what it really means is that by alternative payment models, we mean models that are not volume driven. It's not the more you bill, the more you get paid, period. We are looking to design models that meet policy goals, again, deliver on care expectations and service delivery models. And those often are better suited for some of these alternative care models where you have a direct tie to value within the payment mechanism. We are assessing performance of the system or the provider, and we are rewarding them for achieving policy outcomes that we have all established are appropriate for that service. It also can mean a lot more flexibility for providers, and that's something we are really interested in with this rate study is, as Kylie mentioned, the framework really talks about flexibility. It needs to be flexible, and so payment models need to also be flexible so that providers can innovate, can meet local needs, can meet the person who walks through the door. And those are all things that really lend themselves more towards population-based payments or bundled payments. So we'll get into, again, later, the specifics of all of those different payment options, but essentially just to like open it up with, we will be looking at changing the way we pay for this service. That's an important part of this process, and it does take more time, but it will definitely, I think, be worth it in the end.
Thanks, Olivia. So this information shouldn't be new. I have shared it in multiple settings, but I will just review it again. These are the qualifying community-based mobile crisis intervention standards, or the requirements. So we need to have a rapid response of a multidisciplinary team. That's described in the corner there, what that looks like. They say other professionals or paraprofessionals with appropriate experience. We in Maine are pretty committed to incorporating peers as part of our mobile crisis teams. There's lots of evidence, and we have some successful peer programs already. So we also need to have all of the team members adequately trained in trauma-informed care, cultural safety, de-escalation, harm reduction, confidentiality. We also need to make sure there are standard practices to ensure consistent care delivery. So we want to make sure that every person who enters the crisis system knows what to expect, and that they're able to have a clear, at least idea of what could happen as they move through the system. Each individual circumstance will be unique, and they'll have unique needs, but at least the process and the protocols will be standard so that they can move through the system with ease, regardless of where they may be. We need to have a relationship maintained between community partners. The community-based aspect of this qualifying community-based mobile crisis intervention is very, very key. There is a lot of emphasis at the national level about that community response and making sure that individuals feel a sense of belonging and connection to their community. So making sure that our mobile crisis teams are really integrated with schools, law enforcement, other providers. If there are faith-based communities that are key in the area, or universities, making sure that that connection is strong. And that's all for me for now. Dean, do you want me to just keep going with the slides and let you take over?
Sounds good. So as we're thinking about,
sorry.
Yeah.
I'm sorry. Do we want to maybe, I think we can make it pause for a sec and just see, before we go to crisis residential, perhaps if anyone had questions about what we just covered or thoughts.
Great idea, Olivia. I was going to save questions till the end, but if folks want to ask questions about mobile, then I'm happy to take those now. Or the guiding principles and mission, anything.
Just add one comment. I was speaking with Bree yesterday about the living room, and mentioned all of the different kinds of episodes that a person could have at the living room. So there are prevention activities, there are kind of assessment and immediate intervention activities, there are stabilization activities, and then there are ongoing support activities. So I think in addition to that kind of fourth quadrant in the lower right of the circle, maybe thinking about it across that as well, or adding that to the discussion could be helpful.
Thanks, Ben. It's a great suggestion. Anyone else? All right, if not, I will get us back to Dean.
Sounds good. So as we're thinking about crisis and crisis residential, and we recognize that with the help of Burns quite a few years ago, we've actually have conducted a rate study on this service, though we didn't, I think, end up enacting the changes at that time. But what we're thinking about really kind of moving forward is, same thing in the line with the work that's happening on the mobile side is, really thinking about the framework of the type of services that we, want to support within crisis residential. And, I think the thing that really is probably should be first on the list instead of, as you're kind of, scanning the bullet points, is really looking to forward to exploring what an integrated system for all individuals in crisis would look like. So really thinking about all the different types of, just presentations that folks may have and type of needs that they may have, thinking specifically about folks, with, perhaps a substance use need, or if they have intellectual disabilities or autism spectrum disorders, things along those lines. And, we've kind of recognized that, at least to date, the majority of our system, and when I think of system, what I'm meaning specifically is, those services reimbursed under our Section 65 of our Main Care Benefits Manual has really been focused on mental health, and crises are happen with individuals, across a whole range of needs. And so what we really want to be thinking about and exploring about is how can we support our system to be able to be flexible, to be able to support, potentially anyone who walks in the door. And so I think that's really, a big piece for us to be thinking about kind of moving forward. And, we're going to come up with a few questions, I think, after this to help drive the conversation. But as we're also thinking about in terms of this model and the framework, as you see on that first bullet, we do as a state have a desire to develop a standardized methodology for crisis residential services. Right now, the way crisis residential services are, reimbursed, quite frankly, is by provider. Providers have specific rates there, and we run those specific rates, by our partners at the federal government in order to get approval to be able to reimburse for those services. And what we've realized is that that actually creates a really big barrier to access, services, for new folks who want to really come on board. Um, and so, because what that effectively does is that if any new provider wants to try to deliver a crisis residential service, or then we have to go through the process of federal approval every single time that a new provider is interested in coming on board. And a lot of times those services look very similar, if not, potentially identical to what providers are delivering across the state. And so, we really thought about that and thought about that, potential barrier, and thought that, perhaps what would help, alleviate, that particular issue of, having a really an administrative, roadblock to be able to support new providers is to really work with, you all to develop a standardized methodology that's going to be flexible to cover your costs. It's going to make, sense in terms of reimbursement for the services that you're delivering, potentially provide, some different options depending on, the different models, or maybe different staffing patterns or things that you might need. But, really thinking about trying to have a standardized rate so that we can support any provider who wishes to be able to come on board and not have to continue to seek federal approval for each individual, provider who has interest in this field. So so that's one thing. The next thing that we have been really considering is really thinking about the acuity levels that folks present when they're in a crisis. And so we've recognized that there are some folks that quite frankly need more than what the standard model has been built around to support. And so it's been a barrier that, if you need an additional staff, well, we haven't been able to reimburse for that additional staff because we don't have that flexibility in policy currently to be able to do that. And so as we've been thinking through, we really, are thinking about adding, the ability to consider upstaffing needs for the high acuity members, to be able to do that. And then also really thinking about, again, in terms of being able to, serve anyone's needs who walk in the door, thinking about, SUD treatment and accessing, potential staff to support access to SUD treatment, thinking about how to support to assure access to Narcan, making connections to any MOUD treatments. So really thinking about how we can support, folks across a broad spectrum for these services. And Like Kylie had mentioned on the mobile crisis front, we are also interested in adding peers to our models. There's a lot of value in peers and those with lived experience to be able to support folks throughout, their crisis episode. And so our model currently does not have the, kind of, built-in ability to support that. And so we'd like to be able to create that opportunity moving forward. And so we're also thinking a lot about, in terms of our crisis model, let's say for staffing, and services, really thinking about, medical stabilization and medication needs. A lot of times folks who come into our crisis centers, they may, you know, they can present for any number of, needs, but medication and the, perhaps, the need to, take a look at that and help stabilize or think about a different medication regimen to help someone stabilize, is something that, could be very useful and helpful, and, potentially, prevent future hospitalization. And so thinking about how we might be able to support that within our crisis residential models is something that we're hoping to do throughout this process. And then lastly, thinking about reimbursing for, any type of crisis aftercare. And then so, the ability to follow up with someone after they've, left the, for lack of better words, the residential unit, and they've gone back, and for that team to be able to follow up with them to make sure that they're still feeling okay, and, they're having, the appropriate connections and things that they might need, to be able to have, some lasting, support and there. So those are some of the, kind of the framework and initiatives and things we're thinking about, for our new crisis model. So we do have a few questions, and so what we'd like specific feedback on, and for you all folks to be thinking about as, we move forward with the rate study, is really thinking about, as individuals move through their crisis episode, is there a need for subacute beds for members who no longer, are in active crisis, needing stabilization, but are not yet ready to transition back to the community. So, perhaps creating a bit of a tiered, service approach, to this to be able to handle folks, who need something a little extra, but they don't need the full stabilization, before they head back to their, community setting, whatever that may be. And then thinking about for, adults with intellectual disabilities, autism, crises, what considerations are important there, differentials between children versus adults, whether you're in staffing or, and what the design of the program looks like, board certified behavioral analysts, is there consultation, direct service needs, things like that. And so we're definitely looking for input feedback there. And then lastly, thinking about, again, for those folks, who have substance use disorders in crisis, similar to what we're looking for with ID, but thinking about, what are the important considerations there, and particular staffing needs to either support access or to treat, an SUD crisis. Um, those are my questions. I just ran through them. I invite anyone to open up with thoughts and feedback. We're willing to hear it all. We want to be able to learn from you so we can develop models that really, meet your needs, but also really meet the needs of the folks out in the community who need these services.
I guess a question, kind of a question prior statement. You were linking the standardization of the crisis model to the ability for more providers to deliver the care. And so I guess the question I have with that of the statement is that one of the challenges that we have is in terms of capacity and funding that's tied to that. Beds aren't always 100% full. And if there isn't some sort of process, I'll use the certificate of need process in terms of identifying what is the capacity that we need as a state, you really, if you go into that with that mindset, you're setting it up for failure in terms of financial failure and financial risk, where you actually destabilize the programs, because you end up with a situation with more capacity. Programs then have vacant beds. And so I just have a question about is that if that's your direction of just creating this open field of establishing residential programs without tying it to a need, and how that would impact. And then the other broader question is, I certainly understand the need for being able to serve everyone. There's two sides to that coin. And the other side of the coin that we don't talk enough about is the fact that individuals who are already receiving care also have a right for safety, also have a right for us to pay attention to needs around trauma. And there's that dynamic that plays out that you have to look at those circumstances as well. And so I hope that during this process, we'll be talking about that. Because if it's just talked about on the front end in terms of serve anyone without regard for the other part of it, then we really miss an important part of the service delivery system.
Can you, from my understanding, clarify what you mean about individuals who are already receiving care deserve the, I mean, what do you mean specifically by that?
So if you have a residential program and you have individuals, children that are being served, and a referral for someone else who could present risk or harm to that, to members who are already receiving care, that has to be considered in terms of whether it's an appropriate admission at that time. And what I hear a lot about is the discussion about we should serve everyone, and I certainly agree with that. And we should make that our goal. But we have to also recognize that there are some limitations depending on who we're serving at that moment, the risks associated with that, and you can't just staff your way out of some of those circumstances.
Thanks for clarifying, Dale. I had my mobile hat on and was confused, but that makes a lot of sense. Thank you. Do others have thoughts about what's been presented, questions or concerns?
I don't know if we can even just for Dale's first question about, is it the intention to open up crisis residential to any willing, as we would say, any willing and qualified provider, anyone? I mean, I think my thought, well, I'll let you go first. I know we want to develop a standardized rate. I know we have lots of data-driven ways to look at capacity needs. And I think our growing understanding of need and changing needs is really important to this conversation. But I'll let Dean respond. I think we do have a kind of a phased approach to thinking about that.
Yeah, thanks, Olivia. So we are thinking, obviously a lot about this, and I think as we're kind of going through, we're going to be, continuing to, really look at, where the need is, and so I think there's a number of things at play, and some of which I think also kind of boils into thinking about just broader pieces that really aren't necessarily up for the discussion today, but thinking about the different receiving centers, CCPHC models, and things like that, and how they all start to interplay for our larger crisis delivery system as a whole. But as we're thinking about crisis residential specifically, and thinking about really capacity, I think as we kind of go through this, I mean, we want to hear obviously from you all, in terms of, and looking at obviously as you go through the process, doing your internal rates, things like that, to try to develop things that make sense. I don't know that we necessarily are looking to continue to like expand and expand and expand, and have all sorts of providers, but there are situations where providers have been interested and we haven't been able to move forward because we've had that individualized kind of process. And so I think as we move through this rate setting process, we're going to be obviously talking a lot and having a lot of conversation and coordination of what these rates and development and things will look like, and how everything will interplay with, supporting our delivery system vacancies and, the potential, needs for, certain cases that come in. So I don't know if I'm giving you the exact answer you might be looking for, but I think it's all part of the conversation and things that we want to be, really thinking about as we move forward in this process. And so I think you just raised, a really good point, and just, thank you for that. I don't know if, anyone has anything else they want to add.
I just, Dale, I think that all of this is part of a phased approach, right? That we're not gonna, right now we're trying to develop a comprehensive rate for these two pieces of the service that will help us in future to, once we have some of our data analysis, innovations that we're doing with the MIT Lincoln Lab and other data and capacity understandings will assist us to move forward in the other phases of the work. But just creating, removing the administrative burden is a huge, it's a huge goal of this project, to take away layers of complication. And I think that what Dean was getting at is that it would make it much easier to make any changes if we didn't have those individual called out specific things in our state plan for needing federal approval every time there's a change made. And then that capacity. Also, we need to be clear about what capacity is. Do we have capacity to, or do we have empty beds, or do we have full capacity to have an appropriate place to put the people that you were talking about in the second part of your question, of like, maybe we don't have the capacity to have them here, but we could put them here instead because this is a better fit and they won't be impacting people who are already in our residential services. So, we are really concerned about that as well, making sure that we are able to meet the needs of all people with our, with being mindful of not having someone else's treatment be detrimental to a person who's already in care. So that was a great point too, Dale. Thank you so much for both.
And Dale, this is, I'm Peter Kraut, the rate setting manager. Yeah, that point about capacity and, would CON be an appropriate tool to make sure that you wouldn't have excess capacity, which in turn sets up for financial failure. I think some of that analysis, obviously, and it could be regional in terms of, as Burns collects the data that is necessary to inform. We can't set a rate, for example, until we've established bed size. How many beds for an average facility, because the rate is going to be a function of the size of the facility, obviously. And the size of the facility will, to some extent, be a function of how much capacity is appropriate throughout the state. And then taking into consideration, well, what's the average daily census going to be? Are we thinking that on an average day, it's going to be 90% of beds filled or 80% of beds filled? What do we think? How frequently do we think that peak capacity would be maxed out? I think all of that can be part of the data collection process that would inform the model exactly what the facilities are supposed to look like, how big they would be, which is all necessary, of course, to set a rate. So just to, echo what Kylie and Dean have said, this information can be collected as part of the process. And thank you for bringing up that point.
Are there other questions? Because if not, at this point in the agenda, we'll hand it over to Burns and Associates, and they will, I'm sure they're going to enlighten us and teach us so many wonderful things about the rate setting process.
I'm also wondering too, before, if there aren't any other questions, does anyone have any feedback or thoughts or considerations for the questions that I posed as it relates to folks with ID or SUD, things like that? Because I'd love to hear your thoughts and considerations there as well.
Kylie, can you put those questions back up, because I've forgotten all the nuances of them now.
Yes, just a moment, Sarah. I'm going to try to do that without sharing my whole computer with everyone.
just like to say I really appreciate this approach. It's very thoughtful. And a couple of comments, Dean. So in the adult universe, IDD population, there's different training that we would need to embed, and we would also need to talk about personal care supports and any hands-on interventions, which currently don't happen in our mental health crisis units. And as far as different levels, I think that there's some room to talk about particularly children who are in need of residential services, who get stuck in crisis units, that there may be some capacity building there. And for SUD, I would say something around medical supports and or additional staffing to do observations, especially if there's a detox potential.
Thank you. Appreciate that.
Regarding the beds for subacute crises, we absolutely have a need for that. That would be very much so beneficial to our community.
So, Kim, thank you for speaking to that. Are there any thoughts you can share on what that might look like for us to consider?
I think that we could, I've thought of this before. I think we could almost have like a short-term and a long-term CSU crisis residential, because sometimes people are waiting for certain aspects of their aftercare plan to come into place, and they won't be able to continue to stabilize or maintain in the community until those different treatment services or a residential treatment transition can take place. And so we need to hold those individuals to maintain the stabilization gains that they've had, and they and continue to follow up on making those needs come together.
And are you speaking to children, adults, or both?
Adults. I just work with adults.
I would say the same is true for children, and certainly would, echo what all of my counterparts have said here so far. Definitely a need to look at kiddos who get stuck at crisis units for long-term care that are waiting for a higher level of care, be that residential or whatever the case may be. We could definitely build in more capacity for crisis units. But I think, the big elephant in the room is staffing. Some of our crisis units are not currently running at full capacity because we cannot staff them. And that is a huge challenge. In regards to individuals with ID or autism, the state of Maine has a developmental disabilities crisis team. And so we would have to, they have access to disability crisis homes that mainstream mental health mobile crisis doesn't access. So when you're talking about incorporating into consumers who have those needs into a mainstream mental health service, we have to look at lots of things like, can they attend to their own ADLs? What kind of care do they need? And can we as mental health staff provide that? And I think historically what we've come up against is the answer is no, our staff are not trained PSSs or anything of that nature. We can't do that level of care. We would have to look at that as how we cross train and how we get those certifications and what is the cost in that. And then on top of that, is it clinically appropriate to have someone who has those challenges in a mainstream crisis home? In regards, my thoughts in regards to individuals with substance use disorder, absolutely a medical component is necessary, as has already been said. And we would have to look at the way our crisis units are licensed. Right now, we're not supposed to take people under our license for detox when detox is the sole presenting issue. There are certainly, things that we can do to alleviate that from a licensing standpoint. But I mean, neither of my adult units or my kid units are duly licensed to be a detox center. So there's some administrative work we would have to do there.
Thank you for those really insightful comments, Sarah. I just want to call out, because this did come up internally as well, the Office of Aging and Disability Services crisis system and a disability crisis workers and the state-run system. Those services exist, but they're only for people who are eligible and have the certain waiver that's necessary. And so there are a lot of people in the community right now who do not have that eligibility, or they may be eligible, but they do not have this, they are not covered yet. And so just in the spirit of making sure that we serve everyone, this could be a wonderful opportunity to connect people to that service. But in the meantime, we do need to be able to care for them. And I totally hear what you're saying about all of the complicating factors that will cause. We'll have to work through the licensing pieces and the training pieces. Those are definitely some of our next steps. But just to acknowledge it is a challenge, but it's currently a gap in our service delivery. The people who do not qualify for disability crisis currently are not getting crisis services because our current crisis model doesn't account for them. So we do need to figure out how we bridge those two. And there's some amazing work happening at OADS Crisis right now with the SMART from UNH, and we can work on how to make those connections and hopefully get more people hooked into the OADS system. So I see that as like a stopgap measure for folks who aren't already connected, and that the crisis teams are the people who catch people who slip through the cracks. And that's what's so really incredible about crisis, is that you are meeting people in their most acute moments and helping them get connected to the care that they desperately needed before that time. So I know that it's a challenge, but I definitely think if anyone's up to the challenge, it's our crisis providers.
Kylie, I agree with you. We see a lot of children who are autistic coming through mobile, coming to our crisis residential. And there is one thing I wanted to note. When we're thinking about needs for them, I really feel like, greater access to neuropsych evals would be very important to get diagnoses. I think that OT would be really important to have as a part of that, as well as speech and language. And I did notice the note about access to BCBAs for consultation. And actually, there's a lot of research out there that really shows, when we're thinking about things from a trauma-informed lens, that it's really better for that population to have OT and speech and language, and that behavioral analysis can actually be pretty damaging and traumatic. So just wanted to throw that out there.
Thanks, Liz. Really appreciate those thoughtful comments. And that's a great point, especially, but so just to clarify, speech, language, and OT for adults and children, or just children?
So, well, currently it's it's hard. OT is a hard one to get, reimbursed, but I think it can be beneficial for all. But, specifically here, I was speaking about children.
Thanks so much, Liz.
Hi, Kylie, it's Joe Everett. How are you? Good to see you all. Can I just make a couple points? I'm so sorry, I was listening and I couldn't talk, but I want to add to what Dale mentioned about capacity, that, we really need to look at mobile. I mean, there are less than 87 mobile workers statewide covering 33,000 miles today. And I may have missed this because I was late, but I think that's, to me, where things have to start. I mean, we don't want people in crisis beds if we can resolve their crisis with, what will be 988 and mobile. But I just want to raise that, because that's, we're under siege with law enforcement because we can't keep up with their needs, because they have 3,000 officers and we have 87 or so workers. So just want to echo what Dale said about capacity and then particularly as it relates to mobile. And I just don't know if that point was made, but I wanted to make sure that as we work with Burns and Associates, we have that in mind.
Thanks so much, Joe. That's an excellent point. We're obviously trying to catch people before they get to, these higher levels of care, and making sure that we have all of the pieces of the care continuum will be important. What we have control over right now during this rate study is the mobile and the residential. So trying to make sure that we get those two things up to the qualifying standard is essential. And we definitely are going to be looking at and trying to address the capacity issue for our mobile crisis providers, because it is just a massive amount of responsibility on a very few number of people. So I think through this process, we're hoping that we can have a rate that accommodates, continuous coverage 24/7 to, have our providers be able to be on call, and also just making sure that we use some strategic data analysis to identify the high need areas, and are really thoughtful about how we deploy our crisis teams across the state and where they're deployed from. It's all going to be so important.
Real quick, just to Joe's point, I think one of the things that the advantages, and I think you have a great opportunity, is the fact that you're looking at these rates across many services, not just in silos, and to not lose sight of that opportunity. I obviously there's a need to talk about crisis services in the context of crisis services, but to keep in mind that those other service areas that are being looked at can go a long way to prevent the need for this type of services. And, all you got to do is look at, it was mentioned earlier about the rapid aftercare services and the success that we've seen for children and families and that ability. And that mirrors an existing service. And the big difference and the reason that we're able to deliver the care is because the rates make it possible. It's a different rate structure. And that's really the only difference between HCT and the rapid aftercare is the reimbursement. So I just would encourage that as we go through this process, that we keep that in mind, and that we really support the whole continuum of services, because that's what people really need and deserve.
Couldn't agree with you more, Dale. All right.
Regarding individuals experiencing ID and autism and SUD, upstaffing would help. And upstaffing would be related to the rate and ability to be competitive in the job market.
And Kylie, this is Lori Mitchell for folks that don't know me on the call. I'm the ODE Crisis Program Administrator, so I do oversee the ODE Crisis Program statewide. And I think after listening to some of the folks' comments about the individuals with ID or autism, I do want to thank Kaylee for pointing out that we have identified that there was a need for a cross-training for the ID/mental health population, and we have been incorporating that into the work that we do. But on top of that, the department has also gone under contract with the University of New Hampshire. They are currently on track for completing a systems analysis for us to look at some of the challenges in the behavioral health care system overall with this population, and it's coinciding the work that Kylie and folks are doing here. So I just wanted to point that out.
Thanks, Lori. Jamie Lynn, did you have something you wanted to share?
Yeah, I just wanted to support the need for kids on the autism spectrum who are in need of crisis services. I think we find ourselves in a place where these kids have so many outpatient supports around them that it's either send them right back to that environment or wait for them to get into the DDU. So there's no kind of place in between for them to go at this time. And so I just wanted to share that is definitely something that is needed in the community. Because they also do not have the specialized team that the adults do. And it's very difficult.
That's a really great point. Thanks so much, Jamie Lynn, for pointing that out. And Lori, thanks for sharing about the system analysis and the work happening with UNH. It's really exciting work, and I think there's really some wonderful opportunities for us to learn from that system analysis and to inform the work that we're doing here for the mental health, but we're now, as it's SUD as well, the behavioral health crisis system that we're working to just build out and make more robust. If final thoughts, I would love to make sure that we give Burns and Associates enough time for them to get through their piece, but I don't want to stop this amazing conversation if there are others who have things to share.
I just wanted to add one more thing, Kylie, thinking about what Jamie Lynn said, the children with autism. Some other states are doing, ICF homes. I'm sure you know this, but they're using that as their model and really, supporting those kids with, their behavioral issues. And it seems to be really working very well for some states. So I just wanted to put that out there.
Yeah,
How much did you drink?
that's a really heavy.
Allison, you're unmuted, but thank you so much, Liz, for that. I have looked into the ICF homes, and I think that's a great thing to call out. So at this moment, I think we're ready to hand it off to Stephen. Are you ready to take over?
Absolutely. Thanks so much, Kylie. Let me just bring up a presentation, and I'll try to get through it relatively expeditiously, at least my content, and I'm happy to answer questions as I go along. Kylie, I can still see you. You confirm that you can see my screen now?
Yes, but we can see your screen. We need it in presentation mode though.
Yep.
Thanks.
So in terms of what we'll cover here, I won't spend a lot of time on the About Burns and Associates because we've already done that. What we wanted to focus more on is our typical approach to setting rates, and then some of the things that we'll be doing for this particular project specifically. I'll note that for some of you, you've heard this presentation previously, so I'll certainly forgive you if you want to tune out for a little bit, but I know not everyone's been part of some of the work group meetings we've had over the last couple of weeks. We wanted to give everyone the same foundation. So my apologies in advance for those of you who've heard this before, but we wanted to make sure again that everyone kind of heard the same background information. So this is the scope of work that I've already mentioned. It is, and I think as Dale reiterated, an opportunity to look at the spectrum of services that constitute the behavioral health system, the publicly funded behavioral health system, at least within the state of Maine, and crisis being a key element of that. But you can see here on the page the other specific sections of Maine care policy that we're taking a look at. But for the most part, it's really just about everything that constitutes behavioral health and substance use. In terms of the overview of the organization, we shared a lot of this already, so I won't rehash the points that we've already made. I did make reference to the work that we've previously done. Here are the rate studies that we've conducted up until this point. There's obviously this ongoing project that remains in process. As someone mentioned, I forget whom during the conversation, we actually did take a look at crisis services back in 2015. Ultimately, the rates that we were proposing were not implemented there at that time. It was wrapped up in changes to how the statewide, or at the time what is now the statewide hotline, how the hotline function was going to be administered. And as much as any other reason, that was part of what derailed the implementation of those particular rates. Residential, for example, if I'm recalling correctly, we actually recommended making some rate increases there, but because it was all part of a package covering both mobile, covering the hotline function, and covering residential, when one got held up, they all got held up. So we're happy to be back and taking a look at these services again. I went backwards there, sorry. So with that, I'll pivot to our standard approach to evaluating payment rates. And then, as I said, we'll talk about the particular activities we'll be doing for this project. So given the track record that we have setting rates for a variety of community-based services, broadly defined, we have a process that's standardized, although certainly the details are going to vary from one project to the next. But one of the things that we like to impress upon folks when we're having these initial conversations is what to expect, what the final product is going to look like. And we've used the term or coined the term independent rate model for our work. And the reason that we describe it in that fashion is summarized here in the middle part of the slide, that we're not depending on any single source of information. Rather, we're going to look at a variety of different data sources to inform the development of the proposed reimbursement framework and the reimbursement rates. And so as we'll talk about here in a few more minutes, that includes certainly making sure that the rates are in accordance with and supportive of policies, rules, regulations, standards, and the like. The process does involve feedback from providers at a couple of different stages throughout the process, and there are both formal and informal ways to be involved in the rate setting project. We look for published sources of information that can provide valuable benchmarks for individual cost elements of operating a program or delivering a service. So the parenthetical there includes the example of Bureau of Labor Statistics wage data. And we can talk in a lot of detail about the BLS and what that includes, but the nice thing about it is based upon a very broad-based employer survey. And so any given publication covers a majority of the workforce, if I'm recalling their numbers specifically. And so it gives us a sense of what folks with similar backgrounds, similar occupations are earning outside of just strictly speaking a, say, Medicaid funded system. And then at times we're asked to do special studies. The example of that could be looking at how to accommodate regional differences in cost. So this is something that we had a fair amount of conversation around back in 2015, recognizing there are some rather remote places within the state of Maine and how to make sure that, particularly for a mobile service, providers are being adequately compensated for delivering care in those remote areas. So it's likely that we're going to need to revisit that conversation and think through how that would be most effective. But if we were to summarize what we're trying to accomplish, we really cover that in the first bullet on this slide, which is ultimately we want to build rates that reflect the reasonable costs providers incur to deliver services consistent with the state's requirements and individual service or treatment plans. That's what we're trying to fundamentally do. State needs to define what those expectations are, but once the state does so, we think it's important that the state put their money where their mouth is and say, if this is what we're asking providers to do, whether it's staff qualifications or staff training or the number of people that are going out on a mobile response, the rates need to reflect those expectations. And so ultimately, the product that I referred to a minute or two ago will be these rate models. So we won't simply conclude by saying we think a rate ought to be X per Y, this amount per 15 minutes or this amount per day or some population-based model. It's going to be predicated upon a lot of detailed assumptions. So we'll tell you that for a CSU, we're making the assumptions related to this level of staffing, and this is what the wage and benefit package for the staff operating in the home earn. If we're building any ancillary supports, we'll outline what those ancillary supports are and how much we're assuming from a cost perspective. We'll detail how much we built in for overhead expenses and the like. And that then allows us to be both transparent with you about how the rate was developed or the recommendation was developed, but then also to facilitate a more meaningful conversation so that we're not just arguing over bottom lines. We're actually able to discuss whether or not the assumptions that we've built in are manageable or not. So have we built in enough staffing? Have we built in a adequate compensation package? By outlining our specific assumptions, we're able to get into that level of detail. One of the things that the approach also allows us to do is to build different models, even if we're talking about the same service. And some of these are not necessarily applicable to this particular aspect of the broader project, but some of them are. And so some of the questions I think Dean was driving at related to populations with ID or ASD or adults versus children is, if we're talking about standardizing the rates for a CSU, is it really a one size fits all rate? Or are there other things that we need to account for that differentiate a program or an individual from another program or another individual? Certainly, if we're talking about a differentiated response in terms of who's responding to a crisis or how a program is staffed, we'll want to take that into account. So we might not necessarily build in the same level of compensation for a peer that we would for a licensed social worker. So if we're going to have different responses that are composed or comprised differently, we might have different rates based upon who's delivering that response. And then I touched earlier about thinking about whether or not there is a way to separately consider reimbursement in urban or rural areas, or what the rules look like to ensure adequacy of services across the state. Whenever we build a rate like this, and we use the term home and community-based services, we use that in the broadest possible sense. So we're not tying this just to, say, a Medicaid waiver that covers HCBS specifically. What we're really talking about is non-institutional services. So something other than a nursing facility or a hospital or something along those lines. So when you think about these community-based services or home and community-based services, we're going to always account for 5 core factors. 3 of them relate to the direct care worker, who's actually responsible for delivering the direct support. That's their wages and their benefits and their productivity, which is the time spent on billable versus non-billable activities. And certainly the conversation on productivity, it always begins with what should be billable. So for example, one of the things that we talked about in 2015 was allowing travel time to be billed, particularly in those rural areas, because if you're driving 2 hours to respond to a crisis, there's a cost obviously attached to 2 hours out and 2 hours back. So how do we either build that cost in to the rate for the direct service time, or do we allow it to be billed specifically to account for the time spent behind the windshield? And then the other 2 factors relate to the overhead of the organization, program support and administration. Other factors are going to vary by service. So if we're talking about a shared program like a CSU, what are the staffing ratios that we're accounting for? I think Dale or others brought up the question of occupancy. Certainly for a service where there's more churn than there is in say, a group home, you need to take into account some level of beds not being filled and ensuring that we're still covering those fixed costs, because if you're not able to fill an empty bed the next day, you're unlikely to be able to lay off staff for that 1-day period. That's not going to be a way for you to retain your employees. So we need to take that type of consideration into account as well. Transportation, I've talked about a couple of times already, and the like. So this is not by any means meant to be an exhaustive list, but it just goes to show the types of things that we're thinking about when we're developing these rate models. Because I used this previously, I didn't change the example. It is not the most on point for mobile or residential services, but leaving that issue aside, I should say, it does point to the level of detail that goes into the rate. So this is for a personal care service. You can see the very bottom number in the tiny text is, we're assuming that personal care ought to be reimbursed at $34 per hour. But you can see, and this is public documents, this looks like it's from California, is that 3372 is predicated upon a lot of detailed assumptions about the wages for the direct care worker, their benefits, their productivity, all the things that I talked about on the previous slide. As I said, the first 3 or 5 factors, or the top half of the model in this particular case, relate to the direct care worker. Again, I use that term loosely to cover both professionals as well, paraprofessionals, right? It's meant as a universal term to describe those folks who are delivering direct face-to-face support to an individual. That, as all of you know, is going to be the single largest expense of delivering any type of community-based service, which is why we differentiate that from, say, an institutional service, because running a hospital has less to do with how much you pay your doctors and your nurses and more to do with how much the building costs and the equipment and the prescription drugs and everything else that flows through a hospital. Whereas for all community-based services, including crisis, what we're paying for as much as anything else is staffing support. And so we spend a lot of time thinking about how to ensure that that is hitting the mark that we're trying to hit, which is maintaining a qualified and stable workforce. Productivity, I've referenced a couple of times already. This is the method through which we account for time that folks are working and being paid, but can't bill directly for that time. So like mobile crisis as an example, we talked about travel and whether or not that is a billable or non-billable task, or should be a billable or non-billable task. But you have other things like, say, progress notes or follow-up activities where you're coordinating with another service provider, which might not necessarily be billable. attending a staff meeting once a week or once a month. These are all things that are part and parcel of delivering services, but they can't be billed directly. So we need to account for that non-billable time and ensure that you're ultimately compensated for it. Not in a direct way. If it's defined as not billable, you don't bill for it directly, but you layer those expenses into the hours that you are able to bill for. And then we talked about other expenses, overhead divided between program support and administration. I'll note that program support is particularly critical for most behavioral health services, including crisis service, right? So it's not just the person who's on the front lines delivering care that we need to account for. It is also the infrastructure around that. So if we're talking about paraprofessionals, they're going to be presumably working under supervision of a licensed staff person. So we need to make sure that even if that licensed staff person is not providing billable services, that cost is wrapped into the rate. We've talked about ancillary activities. So if we're referring to a CSU, are there other like counseling services that we need to build in the rate model? Are there, I think Dean gave the example of med management or some medications. Are there things that we ought to be incorporating into the rate? And if we do so, we want to call those out as programmatic in nature, not administrative in nature. So that A, we're both supporting transparency, but B, we're not overstating what is the overhead expense of the home, because those are not truly speaking administrative costs, they're operating expenses. And so I always wrap up this portion of the presentation extolling the virtues of the work that we do. Fundamentally, what we aim for is building a very transparent model. I'm not going to guarantee that folks are going to be in 100% agreement with everything that might get recommended, but you're going to understand what the underlying assumptions were, what data sources were used, and what rationale we employed to develop those full rates. So if I just told you that I think a rate ought to be $34 per hour, like you saw on the previous slide, all that allows us to do is argue about the bottom line. You think it ought to be 35, I think it ought to be 34, and we can't have that informed conversation. Instead, by outlining our assumptions that included a rate of $15.89, I think is what I saw, we can talk about whether or not $15.89 is an appropriate wage or not. And we might not reach consensus on that, but at least you can point out that this is where you think the model works well, or this is where you think the model is deficient, and we can take your feedback and make a determination about whether or not any changes are warranted. The other nice thing about, I think, outlining the models in the level of detail that we do is it allows policy goals and objectives to be advanced as well. And so, for instance, although I didn't point it out specifically, there's a productivity adjustment for training hours. And so it could well be that over time, it's determined that more training is necessary. We're seeing more complex cases, we're seeing more co-occurring conditions, and the state makes the determination that we really ought to have training that focuses on those specific issues. Or Dean brought up providing services to individuals with IED or ASD, for instance. And so without having to go back through a comprehensive, time-consuming and costly rate study, you can simply adjust what we've built in, say 40 hours per year to 48 hours per year to allow for another 8 hours of training. And by outlining the assumptions, you know what's built in, and if a change needs to be made, you know how to make that change. And then similarly, the models lend themselves to being maintained over time, although that does not always happen. By outlining our data sources, by outlining the point in time in which these rate models were developed, folks can say that, well, this was based upon wage data that was published 2 years ago or 4 years ago, or God forbid, 10 years ago. And folks can say, look how out of date this is. If you simply updated the original data sources, now the rate would be 15 or 20 or 30% higher than it is today. Again, this is not meant to provide a guarantee, because the department's not in a position to make such guarantees, since this is always has financial implications, but the models themselves lend themselves being updated, or at a minimum lend themselves to demonstrating how out of date they might be. So from here, I'll just talk and close up and again, make sure that I'm getting through this expeditiously to leave time for further questions, the specific tasks that we'll be undertaking. So this is a graphic that we put together that illustrates the phases of the work. And then I'll turn to the details of each of these here in the subsequent slides. But the first phase is just doing the background work, which is where on the crisis side, at least, we're currently engaged, is kind of thinking through service requirements and how that will impact reimbursement options, providers costs, and the like. We then do data collection, which typically follows, not typically, always follows two paths. The first is primary data collection through a provider survey. And then we like to supplement that, as I mentioned on my very first slide about the independent rate model, with other published information to inform both cost assumptions and then to benchmark our recommendations across, say, what other systems or other states are paying for similar services. We use that to build rate models like what you saw above, although for these services, they get a little bit more complex than something as straightforward as community-based personal assistance. We always have a public comment process that gives providers and other stakeholders an opportunity to weigh in on what we've proposed, what we've recommended. And I will say that every comment process that I can recall has resulted in some changes to the proposals. Once again, I'm not here to promise that there will be consensus on every recommendation, but there will be forums for you to express your suggestions. The department and the consultants look at those suggestions and will likely make some changes, but also equally likely not make all of the changes that are suggested. From there, then we move to the finalization of the rates and hopefully thinking through what implementation would look like. So I'll take each of these in turn, although I won't spend a lot of time talking about it. So I think it may have been either Olivia or Kylie much earlier in the presentation talking about the necessity of this work really following or being driven by policy changes that are being contemplated for crisis services. I'll actually say that that's not really different than any of our rate setting projects. It's never our goal for rates to determine policy. It really is for our rates to reflect policy. What differentiates this particular engagement from some of the other things that we are doing now and may have done in the past is that there's more, I think, systemic changes in the offering, right? So we're always looking at service requirements and helping states think through them. Are they documented well enough? Can we understand what providers are being asked to do? Are there opportunities to refine what those expectations are? So we always think about whether or not there's tweaks that ought to be in order. Of course, here we're talking about something that is more meaningful than tweaks. And so that's what I think differentiates. Not that we don't always do that work, because we do, but this really is ensuring that, as decisions are being made about how the state wants to structure the crisis system, that ultimately that gets taken into account in the development of reimbursement options. We always like to have some conversations around those requirements, and that's the purpose of us being here on today's call, so we can hear what providers think about how things are working today, and more importantly, perhaps react to some of the thoughts that the department has or that this community has about how things can look tomorrow. A couple of points on the provider survey. Obviously, for some of you who are part of agencies that deliver any of the other services in the scope of work, you've already hopefully received the provider survey that we're conducting. There will be a separate survey for crisis services. It's important to acknowledge that the survey is by definition always retrospective. So I just spent a minute talking about the importance of building rates that reflect the future state. What do we want the crisis system to look like? This is not contrary to that, but there is going to be that reality that we're asking about how services are delivered today and what the cost of delivering services today looks like. We still think that that's eminently valuable because although we might be talking about changes to the overall structure of the system of supports for crisis, there's probably some still important takeaways that we can glean from the provider survey. But I do want to note that for this particular component of the project, more than any other, there is going to need to be a lot of thought given to the difference between current service delivery and how that impacts providers' expenses versus future service delivery, and where it is and is not appropriate to use some of the current information to inform a future reimbursement model. I'll note again, that's not dissimilar. It's perhaps amplified for this project, but it's not dissimilar to all our work constantly. The surveys are always backwards looking. Rates are always meant to be forward looking. And so for that reason and others, the survey is never meant to dictate rate models. It's meant to be one of multiple informants that we consider when we're building a reimbursement framework. And again, as the survey's out in the field, it's a not insubstantial undertaking to complete the survey. we're aware of that. So we certainly endeavor to provide technical assistance through a variety of different channels. And then we'll provide analysis, and we'll be reporting that analysis back out publicly. Never provider specific information, but we do say that this is what we learned from the provider survey and put together at a minimum a packet of data that produces or summarizes those results. I mentioned as part of my remarks about why we've adopted this approach to rating, this independent rate model approach, and it really is because if all that we rely upon is current cost data, it becomes very much a circular argument that providers' expenses are tied to current reimbursement. So if we use that to justify future reimbursement, it's going to look pretty much the same. And when we do this again in 5 years, it's going to look the same. In another 5 years, it's going to look the same. And so for that reason, it's important for us to look externally as well to other sources of information that can inform both individual cost assumptions like wages, as well as provide a reference point for bottom line rates. To that last point, we never build rates based upon what another state is doing, but it is, I think, instructive to see how what it is we come up with compares. So it's an after the fact exercise. We do our work, but then as a reality check, we do see, well, what are other states paying and are we within that range? If we're either really high or really low, we're going to want to look into that. Doesn't this require us to change, because we like to think that our rates are wrong and everybody else, or our rates are right and everybody else's are wrong. But even still, we want to understand if we're an outlier, why that's the case and if it's justifiable or not. And so then we develop the rate setting methodology. And this will be certainly and obviously the critical element of this work. So I don't want to leave you with the impression that I'm undermining anything that's been stated previously. So in both remarks that Kylie and Olivia and Dean made, we understand and are on board with looking at not just the rates as they exist today, but thinking about the underlying structure of reimbursement. So someone mentioned for mobile that they don't think it's going to be, strictly speaking, a 15-minute unit. And so there's a lot of things for us to think about. What is the best approach to reimbursing for services? Should it be 15 minutes? Should it be a per diem? Should it be a more population-based payment that's made for a catchment area? So there's lots of things for us to consider as it relates to simply building the structure, even before we get to the amounts, which I think is one of the points made in the earlier presentation. We need to think about what the structure is going to look like. And then to some of the points that Dean raised in his remarks about crisis residential, the conversation is, well, what gets built in, what's bundled as part of that rate, and what perhaps is done on an a la carte basis. So I don't have answers to any of those questions today, but we know that there are a lot of questions to be answered. And it goes beyond simply saying, this is the current 15-minute rate for a crisis, mobile crisis, and this is the current per diem for crisis residential. What are going to be the new rates for those two things? That this is a much more fundamental undertaking or analysis of the best way to reimburse services to achieve the types of outcomes that have been articulated previously in this presentation. So the building the rate model structures here is going to be, a big lift to make sure that we're thinking about how to reimburse and what gets bundled, what doesn't get bundled, and the like. Once the structure is built, the actual population, the rate models with the cost assumptions flows much more smoothly, right? We'll think about how much we want to believe is a reasonable wage or compensation package for folks who are delivering care and the like. And then we have a public comment process, which I alluded to a few minutes ago, where once we make our recommendations, it's never meant as a fait accompli, that will provide the forum for folks to weigh in on that through a formal process where folks can submit written comments. And then we provide, again, a transparent document that says, this is what we heard. And if we make changes, we explain those changes. If we don't make changes, we explain our rationale for not having done so. From there, we'll finalize and publish the rates and ideally move forward with implementing those recommendations. Of course, implementation by itself is a massive lift, particularly if you're talking about systems change. So we'll be providing whatever support the department thinks is warranted from us to help think through what an approach is to get from the current state to the future state. And does that need to be transitioned over a period of time? Are there some things that can be done immediately? Are there some things that have a longer fuse associated with them? Obviously, a lot of work goes into thinking how to implement such significant changes without disrupting the current structures, the current systems that are in place. And finally, this is my contact information. You also have the information, obviously, from the state folks, so they know how to get a hold of me as well. We're here to help once we start doing the nitty gritty of the rate development process. So if you have questions about our role, about the provider survey and the like when it comes out, you can contact me. Carl's name will be attached to all the other documentation, and he's more affable than I am, so he's always happy to talk about these issues as well. So you'll have his contact information on future documentation. Again, I typically spend more time on this. Some of you have heard it before, but I wanted to get through this so that there's time for questions, both on the rate setting piece of this, as well as to leave room for additional conversation about the more programmatically driven issues that were raised earlier in the presentation. So I'll stop talking now. Any questions for me and what we're going to be doing on the rate setting side?
There was a question for you in the chat, Stephen, from Tess saying, how are turnover rates and staff retention incorporated into the study? For example, if rates of pay are higher, it will lead to lower turnover and higher quality services by retaining quality experienced staff and improving client outcomes.
So to start with the broader perspective that I shared, it's for recognizing that there's a strong link between current reimbursement and current cost data. We do look for other sources of information. And so when we're looking at those other sources of information, we're trying to build something that we think is a reasonable and competitive market-based compensation package for the individuals delivering services. And so when we do that, we look at things like the BLS. At times we take a look at job postings, which are not focused just on the publicly funded or Medicaid funded side of the behavioral health system, just to understand what is the going rate out there for a social worker, for example. And so that's what we're trying to do simply when we're building the rates, is to make sure that it is based upon what the market is requiring that folks are paid, even if that's more than what they're able to pay today based upon the rates they're currently receiving. As it relates to turnover, we do aim to take that into account in a couple of ways in the rate model. So for example, training is one element that is directly impacted by turnover, that there's always that onboarding process where people are less productive, in their, say, first year of employment than they are subsequent to that. So when we build in training expectations, it really is meant to reflect an average of some people are always being onboarded and other folks are in their job for a longer period of time. And as a result, the training needs for those staff are lessened. And then outside of that, when we're talking about turnover expenses, it doesn't show up as a separate line item in the rate model, but certainly the costs that we've built in for, say, administration includes things like human resource functions and the like, which get reported through the provider survey. So those are the couple of ways that we're trying to take into account. How does that impact training and productivity? What are the other infrastructure costs associated with the hiring function? And that gets built in, again, to those larger categories. We don't have a line item specifically for human resources any more than we have a line item specifically for finance or for IT. It's all part of that administrative overhead expense.
Does that answer your question, Tess? Any other questions?
I had a question in regards to how the rate study will address, we have a continuum of staff that are employed through all of our agencies, through all of our programs, ranging from high school level staff to clinically independently licensed staff. And we're, currently in a staffing crisis. I think worldwide we can say we're in an employment crisis, and looking at how do we reimburse staff to come and do this work in a equitable, marketable way, that they don't just go to McDonald's instead, because they can make just as much money there and not have people spit at them and throw poop at them and yank their hair out.
So to the first point about the range of staff, yeah, we certainly wouldn't build a rate that assumes people with bachelor's degree or that are operating under an independent license are being paid wages that are comparable to what they could earn at McDonald's. So the idea here is that we don't think it's ideal where there's a single rate that covers a huge spectrum of qualifications, right? Because then you're tasked with determining what that mix looks like. If you build it based upon the lowest common denominator, that maybe the only entry requirement is a high school education, well, you're not going to provide any incentive whatsoever for hiring people with greater qualifications. You're not going to be able to afford them, in other words. On the other hand, we don't want to build a rate that assumes that everybody has a college degree, if that's not the case, because similarly, you're not providing an incentive to actually hire those folks. And one of the fundamental tenets of Medicaid reimbursement, if you look at the law that covers reimbursement, it talks about rates need to be consistent with efficiency and economy, and paying everyone at the top end of the qualifications is not consistent with that Medicaid requirement. And then furthermore, you can do an average, but the average kind of gives you the worst of both worlds, right? That you're paying too much for folks with the low end of the qualifications and still paying too little for folks at the high end of the qualifications. So then there's the conversation we had about, well, how do we differentiate, or create rate differentials based upon the service being delivered or who's delivering it? That's not easy to do in the types of services we're talking about here today. So I don't have an answer about exactly how it's going to shake out. It's definitely the type of thing that we'll be giving consideration to, because for something like a skilled nursing service, it's a lot more straightforward. You have one rate for RNs, you have another rate for LPNs. When we're talking about needing to staff a program and having differential responses at time, we are going to need to absolutely give thought to what presumptions we're making, how those align with the documented requirements, and making sure that we are providing the appropriate incentives for employing the more qualified staff. Not to say there's not a role for paraprofessionals as well, but we need to make sure that we're being fair to all staff, both paraprofessionals and more professional staff, while being compliant with Medicaid reimbursement laws. So I didn't give you a specific answer because I don't know what the specific answer is going to be, but it's certainly an issue that we're always cognizant of and look to take into account when we're doing rate setting.
Yeah, and I'll just add, Stephen, that team-based care, multidisciplinary care is a requirement of qualifying mobile crisis services and something that the department heavily is supportive of. And so if I'm not sure, some of our models that Burns has done in the past, even the behavioral health home model is a team-based approach. And what I think is really important about where we have an opportunity here is that while there's incentives within the rate, that we also are we're going to make this an incentive-based service. So you are going to be able to have incentives to innovate and decide which staff do I deploy to most appropriately meet the needs, be most timely in my response. And if you are meeting those targets, there's a financial incentive tied to those outcomes. So it's like, we want to balance that rigidity or the necessity to make assumptions within a rate model with incentives for performance, so that if you're reaching the health outcomes or the policy outcomes, that also is an incentive to help play into decisions about staffing at the provider level, while of course the rate model itself has to have some concrete assumptions in order to end up with the dollar amount. So I think it's going to be something where, again, team-based care is complicated in that way, but when you make it a value-based program, you also kind of add a layer of financial support to providers to do what they think is best with their team.
And I think the point you raised, Olivia, is that it's just hard to divorce most of these issues from the overarching, how do we want to reimburse the service, right? So if you look at the work that we've done for behavioral health homes, if you look at the work that we've done for ILPs, they've lent themselves to this team-based model that accounts for all the team members, going from psychiatrists down to peers. And then the reimbursement model for those, for a number of those at least, is like on a monthly or weekly basis. So we're covering the entire cost of that team. Again, I'm not here to predict exactly how this is going to come out, but those are the types of, I think, options available to us. And certainly we have precedents for that in some of the recent projects we've done with Maine Care in the last couple of years.
Thank you.
questions for Stephen? If not, I can wrap us up with some next steps on the programmatic service delivery side. And then Dean and I will co-host that part. All right. So this mirrors what Stephen was saying about having to assess our base funding needs. So, and to what Olivia was saying as well, like, let's figure out how much is it going to cost to get us from where we are to where we hope to be. Thinking about 24/7 availability in the firehouse model, funding and staffing that will enable providers to engage in community outreach, education, and relationship building. I know you already do that. When I say that, it's because we want to encourage that community building piece and make sure, especially with the increasing need and how hard it's been with the workforce, that we're really building that into this as well, making sure that we're allowing you to do that work. And ensuring appropriate distribution and capacity of the teams and residential beds to meet the need. To get to Joe and Dale's point earlier, really looking at data, using data to inform our decision making, and making sure that we understand the needs in each of the regions and districts. Figuring out a sustainable way to include peer support in the crisis models without having it go against the certified intentional peer support model. There are some experts that we'll be bringing in to help us to see how other states have done that. And costs associated with licensing, certification, and training needs, which has been brought up by many people as we broaden our definition, which is the next phase. We'll have to revise our definitions of behavioral health crisis in policy. And right now, as you all know, it says mental health or co-occurring, but we really do want to broaden it to be any acute mental distress that has made a change in somebody's functioning ability. That's not a very graceful way to put it. We can workshop that. Safety and imminent risk is going to be so important to figure out our protocols to make sure we all universally across different departments, even Department of Corrections and Department of Public Safety, law enforcement partners, that there's clarity around what is safe or unsafe. Medical clearance is a big one for residential. We've talked about that at length, how we need to make sure that our definition of medical clearance is clear, and that we aren't putting people through undue steps, like sending them to the emergency department if that's not necessary. And then the subacute and transitional settings for residential, making sure that we know what that might look like, what that would entail, what the criteria would be around that. And then standard practices, dispatch protocols to make sure that we're very clear on how 988, this is, programmatically, we're going to have to figure out how 988 rollout is going to impact our revised mobile crisis model, and how those two things will work in tandem. Again, clarity around scene safety, co-response, when's that necessary, when wouldn't it be? I think a step-by-step guide to assist the public with system navigation is a huge piece. Just once we have clarity around exactly what our uniform standard practices are, making sure that people who might be afraid to call because they don't know what to expect can look up and see clearly what to expect. And then, just ensuring that consistency statewide when we move towards implementation. And I am so excited to be embarking on this work collaboratively, because I think that the more buy-in we can get from our providers who are doing the direct care work right now at the forefront means that any changes won't come as a shock, and it will be much easier to do sustainable implementation of any of the new qualifying standards. So any questions about that? All right, and the last slide I'll just leave up is, if you don't have it already, here's my contact info and Dean's contact info. You can reach out to either of us. I'm thrilled to be to receive an entire inbox full of suggestions, thoughts from all of you. I am grateful for the opportunity to learn from you as we work towards our reformed model. I don't know, I can't speak for Dean, but if you want to fill up my inbox, please feel free. And I can pass anything along to Stephen as well. If you feel more comfortable reaching out to me, I can make sure to get your questions to Stephen and his team too.
My inbox is full enough. Thank you. No, I'm kidding. So yeah, I mean, obviously, as we work through this process, I mean, we really want your input and your thoughts. You know, particularly as it relates to, you know, model reform. You know, we were really committed to trying to get this right. You know, and right from, you know, what the, you know, department, you know, initiatives are, but really from what's going to work out in the community. And that really needs to be, you know, informed, you know, by you all, and we need to be partners in this process. And so any thoughts, you know, that you may have that you want to share with us, you know, as we think about the models, we definitely want to hear them and potentially, you know, engage in further conversation around it. So, you know, please, please do reach out to us. So thanks. And with that, you know, if there's no other questions or concerns, I guess I'll pause a moment to see if there's any other thoughts, questions, concerns, you know, insults. I saw that in another presentation. Anything that anyone wants to say? We'll give a moment, and then we might just close up.
Is there going to be another meeting like this one coming? Are we having individual discussions with you per agency? What is the next thing that we need to look for?
I think that we can collaborate with the existing OBH OCFS provider meeting and use that as a venue if that works for the teams that run that meeting, or we can set up other meetings to continue the conversation. I think for right now, we're just trying to kick off the rate study and make sure that we're all aware of what we're doing. And then we'll follow up with you once we've had a chance to debrief about this kickoff meeting internally about our cadence for meeting ongoing.
Sounds good. Any other thoughts or questions? Or anything else that anyone wants to add? Hearing nothing. I just wanted to, you know, just take a moment and just thank all of you for, you know, sitting with us for over the past, you know, almost 2 hours, you know, really kind of going through and you know, conversing with us, engaging and giving us some, you know, great points to think about as we think about, you know, updating our crisis delivery system, both from a mobile and from a crisis residential perspective. You know, really looking forward to continuing to work with you all through, you know, the future stages of this project, and looking forward to seeing what we can accomplish together. So I think with that, you know, just thank you very much, and, you know, we'll look forward to the next steps.